Welcome, everybody. I hope everybody had a nice holiday weekend. I guess we have a return of summer for one more week. And a couple of announcements before we formally start grand rounds. Is Todd Brugos here by any chance? No. So we have a new PA that's officially starting yesterday, Todd Brugos, and he's going to be working with the hand team, primarily under the supervision of Dr. Kennedy at Northwest Hospital. So welcome, Todd. Todd came to us from Overlake. He's your PA, correct? Mostly Chelsea? Oh, okay. All right. Lucky for Todd, he has both Dr. Bowe and Dr. Kennedy. And then it's also my great pleasure to welcome Kevin McDonald back to the department. Kevin, you want to give a little wave? So Dr. McDonald trained at University of Wisconsin. He did his tumor fellowship here about maybe 16 years ago. Is that right? And then went back to Wisconsin and then has spent about the last 15 years at Virginia Mason. And so Kevin is joining us to be a half-time tumor surgeon and half-time total joint surgeon. He has a great reputation around our community and nationally, and it's really nice to have him back joining the department in the tumor team. And I see Dr. Roberts shaking his head affirmatively. A couple of kudos. Congratulations to Nate Callender, who won the Outstanding Consultant of the Year from the UW Emergency Medicine Resident Program. It's really great when an orthopedic resident wins that. So congratulations, Nate. Kevin Koo got some great feedback, which was referred to as an MVP performance by one of the UW Medical Center anesthesiologists. She had said Kevin was the most helpful resident or fellow she's ever worked with, and that comment came to us via Dr. Schiffman. And then Ellen Goldberg got kudos from a member of the department who needed care for their dad. They wanted to commend Dr. Goldberg for the exceptional job she did. She was extremely professional, attentive, and helpful. So thank you, Ellen, if you're here or on Zoom. Just so everybody knows, we do have now about 30 people also joining us for Zoom. And with that, I'm going to have Dr. G introduce our special visiting professor for Grand Rounds today.
It's actually nice to be back with you guys in person. I know we've had a few of these in-person Grand Rounds, but maybe we can have a few more in the future now. So it is my distinct pleasure to introduce David Patterson, Dr. David Patterson, who I think a decent number of us in the room know from when he was a resident here. So it's great to have David back. And then, like a good resident, David wrote me a little blurb about him so I could introduce him really easily. So that relationship is still working out, David. But now I consider him like a good former. I was going to say, like, you're a colleague now, but it is very appreciated. So David Patterson was one of our former residents here. He graduated probably about 12 years ago, maybe 11. I think you were a chief when I first started my practice, and I've been here about 11 years, 12 years. So that's really cool. So David went off to the University of Iowa to do his fellowship in sports medicine, and then took a job in Detroit, and then worked there with some of the pro teams for a while. And I think was part of the residency there for a while too, correct? And then I think you transitioned. He's now at the University of Michigan. You're the chief at the VA there, which is kind of a proud thing since I enjoy working at the VA too. And I think that's kind of where we cut our teeth together, if I remember correctly, 12 years ago. You're the team physician for Eastern Michigan, which is one of the reasons that you're here this week, which is awesome. We're playing Eastern Michigan this year. I left out the part in your blurb where he said he was, at the University of Michigan, the national champs from last year, because I'm just not going to talk about that. And then he is the president of the Michigan Orthopaedic Society. Is that right? Yeah. So he's doing great things in his community, doing leadership things, doing awesome things in the world of sports medicine. So it's really cool to have him back to give grand rounds today in conjunction with John Bartoletta, our resident. They're going to talk about osteotomies around the knee joint. So David, welcome. John, I'll have you up to the podium to start the grand rounds.
Thank you, Dr. G, Dr. Chansky. Good morning, everyone. I'd like to welcome you all to September Grand Rounds. I'm John Bartoletta, one of the fourth-year residents, as Dr. G mentioned, in the department. I'm joining Dr. Patterson today on a discussion of high tibial osteotomies, and we'll focus on the history, present day, and the future. Prior to Dr. Patterson's talk, I'll be focusing on the history of high tibial osteotomies. Dr. Patterson will lead us through its current use and where the field is heading in the future. So we'll go back quite some time. The principles of deformity correction have been understood for quite some time. Deformity correction was established as early as 400 BC. Here shown on the right is a traction device developed by Hippocrates that allowed for traction to be applied to any bony structure of the body. In his Corpus de Fracturis, which was written in about 415 BC, mention is made of using a new traumatic fracture aid with improving the alignment of a previously angulated humerus, which is thought to be this device. Following this observation, he developed this traction device to realign bones as they healed. There's some debate on the interpretation of this device, such as the shape of the holes down the middle, as well as the height of the posts down the side. Nonetheless, it was well established at that time that broken bones could be reduced using traction. Interestingly, though, reduction of fractures using direct manipulation has not been described until the 19th century, though it probably was occurring. These types of devices were used for continuous traction in the 1300s, and subsequently in the 1500s, deliberate closed reduction and splinting of fractures led to the development of osteoclasis, wherein bones were intentionally fractured and realigned for deformity correction. The term osteoclasis comes from the Greek osteo meaning bone and klasis meaning to break. Advances were slow during the subsequent 3 centuries. Poor antisepsis, limited understanding of the underlying biological principles, little dissemination of new techniques, and rudimentary operating equipment were significant obstacles to refining techniques in deformity correction. The first successful surgical osteotomy about the knee was published in 1835. John Barton performed supracondylar femoral osteotomies for ankylosing knees with what he described as a good outcome in 12 of 14 patients. The remaining 2 in the series perished perioperatively. Between 1835 and 1935, osteotomies performed about the knee were primarily limited to the distal femur. Complication rates were high and techniques, they varied widely. Langenbeck, using techniques adapted from his experience in the war in Germany, performed several osteotomies about the knee for rachitic deformity and ankylosis in the 1850s. He drilled an aperture and inserted a small saw to almost complete the osteotomy before applying lateral force. Unfortunately, infection rates were high, he attributed initially to a foreign body reaction to the created bone sawdust. Professor Pancoast in the USA reported using a stout gimlet, as shown on the right, to create multiple perforations at a femoral osteotomy site through a single small incision before applying a corrective force. In his paper in which he describes this, infection still ensued in the single patient, but he described a good eventual recovery. Osteotomies were then performed regularly for wide-ranging indications. Techniques varied dramatically and were not well kept. On the right is a figure from McCowan in 1879, in which they reported on a transverse femoral osteotomy technique to correct genu valgum and anterior tibial curves, which he used in 50 cases. He described a medial femoral approach that avoids significant vascular complication and warned against correcting with a quick jerk, rather advising the bending ought to be performed gradually. Osteotomy of the tibia combined with the fibula was first performed in 1928 by Sir Robert Jones. Then in 1935, Brett performed the first osteotomy distal to the tibial plateau, most proximal to the tubercle, for treatment of genu recurvatum. This occurred in a young woman of unknown age who developed polio in childhood and developed a hyperextension deformity as a result of muscle imbalances. An incomplete osteotomy was performed using an osteotome, as shown here. And bone chips were added as a graft. At last follow-up at 1 year, the patient was noted to have resolution of her deformity without pain, and her osteotomy went on to union. As we progress through time, in 1961, so 30 years later, Jackson was the first to publish high tibial osteotomies for deformities about the knee caused by degenerative joint disease. Interestingly, in their series of 11 patients, they only included those with valgus deformity. Their osteotomy technique is not well described, but was located distal to the tibial tubercle. And the images above, figures from the manuscript, demonstrate clinical and radiographic alignment 9 months after surgery, and we presume these are not from the same patient. They report 100% relief of pain in their cohort, which occurred, quote, immediately after surgery for the majority of their patients. From their paper, they state, femoral osteotomy in most knees with a valgus deformity on radiographs show that the angulation is at the lower end of the femur. If an upper tibial osteotomy is carried out, the leg can be made to look straight, but the joint line remains tilted. 3 years later, Wardle reports on HTOs performed for 38 knees and 35 patients, with the HTO being performed distal to the tibial tubercle at the junction of the middle and proximal 1/3 of the tibia. They reported in their cohort complete relief of symptoms with improved range of motion in all patients. Interestingly, they hypothesized that reduction in pain was due to reduction in intramedullary venous pressure from the osteotomy itself and not due to the realignment of the joint line. Prior to the 1960s, the majority of surgeons were using plaster casting alone to maintain correction following their osteotomies. The first use of internal fixation was published by Garapi in 1964 with the use of staples. Subsequently, in the 1960s, Coventry from the Mayo Clinic developed the stepped staple, which you can see on the right, as staples frequently loosened because they often did not engage fully with the distal tibia, as you can see on the left. Simultaneously, the awareness of fixation principles as developed by AO led to the use of T-plates as well as fixed angle blade plates for fixation. Here we can see the first published result of using these two techniques. Other approaches included the development of the interlocking wedge osteotomy to increase bone contact surface area. Here shown on the left is a description of a technique in which the anterior and posterior cortical bone is left in place such that the osteotomy interlocks to increase stability. Interestingly, at this time, they are also doing a fibular osteotomy, and I think Dr. Patterson will briefly talk on this in his talk. Long-term studies then published in the 1970s demonstrated complications, as we had about 10 years of data at this point. These included non-union, fixation failure, displacement of graft, as well as perineal palsies. New questions and techniques emerged, including the use of internal fixation, identifying the optimal correction angle, as well as identifying the optimal patient for HTO with the development of the total knee arthroplasty. Furthermore, when to include a distal femoral osteotomy, as well as optimal shape and location of osteotomy, all needed to be fleshed out. Routine introduction of the total knee arthroplasty occurred in the 1970s to 1980s. Shown here is the total condylar prosthesis, one of the earliest condylar resurfacing total knee arthroplasties, consisting of a chrome cobalt femoral shield and a polytibia and patella. 10 to 12-year follow-up began to demonstrate favorable outcomes and indications, and ideal patient selection for HTOs needed to be developed given the new use of a total knee arthroplasty. As we mentioned, angle of correction also needed to be determined, and a landmark study that is often quoted is published in 1979. They examined the mechanical axis and arthroscopic grade of degeneration before and after high tibial osteotomy in 54 cases. On postoperative arthroscopy, which is a sample that's shown down in the bottom right, they found arthroscopic evidence of articular cartilage regeneration with fibrocartilage and meniscal repair when the mechanical axis passed through a point 30 to 60 degrees lateral to the midpoint of the tibial plateau, confirmed by histologic analysis in 20 of these patients. These findings have been subsequently reproduced between 1979 and a number of trials between 1979 and 1999. Overall, while there are multiple methods for recording angular correction, the consensus opinion is that correction in the presence of degeneration should be beyond neutral. However, up to this point, intraoperative correction was left to the discretion of the surgeon, and no formulaic method had been developed to meet the desired correction needs. In 1989, Minasi published the results of their method using a 5-hole 1/2 tubular plate as a fixed angle device with osteotomy planned off of the long length radiographic films as shown from the 2 figures in their manuscript above. This is the first manuscript to describe a preoperative technique or preoperative plan to achieve a desired correction angle. As you can shown above are the preoperative, postoperative, and last follow-up femorotibial angles demonstrating adequate correction that was maintained at an average follow-up of 22 months. This framework, again, or as we all know, was further refined by Paley, the definitions of the LDFA, MPTA, as well as the CORA. Through his work, he defined a system for which deformity correction can be employed based on the center of rotation of angulation. And as we all know, a new option developed for unicompartmental disease with the introduction of a unicompartmental arthroplasty. Shown here on the slide above was a figure that Dr. Patterson was able to find with a patient that had a high tibial osteotomy on one side and a uni on the other side. Recent meta-analysis published in 2017 of 1,000 patients and 15 studies comparing high tibial osteotomies to a unicompartmental arthroplasty. They found no difference in walking velocity, knee outcome scores, deterioration of contralateral or patellofemoral joint were identified between the 2 surgeries, though HTO had improved primary outcomes, defined as the primary outcome of each individual study, and was not uniform, as well as no difference in revision rates between the 2. So in conclusion of the history and where we are today, we understand that the understanding and application of deformity correction is about or greater than 2,000 years old. High tibial osteotomies were initially developed for the treatment of rickets and later applied to degenerative joint disease in the 1960s. Consensus is overcorrect the mechanical axis for a varus knee, and today high tibial osteotomies are best suited for young patients with activity limiting pain for degenerative joint disease in a single compartment. Thank you.
Okay. Okay. Oh, there we go. Okay. All right. So thank you everybody for coming. This is fun to see people in person. Really appreciate seeing some old faces. So no conflicts relevant to this other than that I really enjoy cutting bones, doing that along with soft tissue surgery. So we'll talk about a few different things and not going to get into too many specifics about some of the technical stuff. That stuff is fun, but hopefully a different way to think about some of these problems. Primary OA, why not a uni, and concerns that I have about abandoning the procedure and then losing it altogether. Patellofemoral surgery, and with a discussion on rotation, and then ACL. So understanding when we're dealing with a slope like that versus a slope like that. So we'll start with a simple 44-year-old that had an osteochondritis dissecans lesion that he had a allograft for when he was younger. Now he's grade 4. He's about 4 degrees of varus on this side, and he's failed everything, and he's been told that he needs some sort of arthroplasty. But he teaches fitness classes, and his arthroplasty consultant told him, you know, you're going to have to give up a lot of that fitness class stuff that he does. He does like steel mace training and then high intensity like hill running. And so maybe we should just jump to the last operation first. Michigan has a really robust prospective registry for arthroplasty, and revision rates for total knees are exceedingly low, way better than anything else we're going to talk about for the knee. But we also know that your youngest patients are the ones that are the most likely to be dissatisfied, whether it's because they haven't suffered long enough in life to really understand how good their knee can be with an average arthroplasty, or it's that they have higher demand. They see their friends and family out doing stuff and they're doing more than just walking the dog. We know that dissatisfaction is higher in younger patients. And unfortunately, those younger patients are also the ones that end up revised most frequently. This is from the Australian registry, and the highest conversion rate is in younger patients. So what about unis? Unis have better satisfaction rates, quicker return to work. That's awesome for a younger working population. And so if satisfaction rates are higher, why not just throw a uni in everybody? Unis are problematic as well. And again, the dogma of a uni for a younger patient isn't doing us favors, because these have the highest rates of conversions from total. And if you look at these side by side and then adjust the y-axis, you see just how concerning unis can be 20 years out. These patients that are, in their early 40s and younger, it's a coin flip whether they're having a conversion before they retire. Now, conversion total after osteotomy is no cakewalk. This is an actual patient that I was involved in at the Seattle VA. Shout out to Bill Blackburn for getting a custom prosthesis made for us. And these are all technically demanding. Patella baja was very common. With some of those older fixation methods, people would be casted for a long time, non-weight bearing, soft tissues contract. And then surgeons like Dr. Manor are muttering under their breath about how this is a pain in the butt to do.
That's still functional.
He's still.
Yeah. And we should know we did not do that osteotomy.
We did not do the osteotomy, but he had his totals done at the VA. So fortunately, we don't see this creation of a deformity with modern opening wedge techniques. So then the concern is always, are we compromising later arthroplasties? The Mayo group looked at their patients, and essentially their data highlighted the conversion total knee from osteotomy was most similar to primary total knee when they controlled for activity and demographics, although they were longer operations. But unis do compromise later arthroplasty. This is the Swedish experience. Conversion total after uni had a 3-fold higher revision rate compared to primary. And revisions for closing wedge conversions were higher, but opening wedges were not. And so additionally, far more frequently needing revision components in your conversion arthroplasty. This was backed up in the Korean database. They looked at revision rates for primary total knees, conversions after osteotomies, and conversions after unis. Re-revision after unis was 2.5-fold higher than osteotomy. And similarly, the Danish registry also showed worse survivorship for your conversion totals after unis. This was a nice study that came out a couple years ago, and I wasn't really sure how to put it, but the perfect internal control is the patient who had a bilateral total knee, but only had an osteotomy on one side. This was out of the Mayo Clinic. They had 25-year follow-up, and they looked at patient-reported outcomes, forgotten joint scores, and revision rates. And basically, they were all doing the same. So the perfect internal control, the patients were equally satisfied with both, with the same longevity. We live in a time where currently our implant selection and the costs that we pass on are passed on to the insurance company, but we're kind of shooting ourselves in the foot by choosing expensive care for our patients. So what's cost effective for younger patients? This was a study looking at patients between 50 and 60 with probabilistic models with outcomes and costs. And depending on your willingness to pay threshold, 2 common levels at 50,000 per quality adjusted life year or 100, osteotomies were still deemed cost effective in patients under the age of 60. And this is where I get really kind of concerned, is because this is becoming the forgotten art. This was a study out of Ontario 30 years ago. or 40 years ago now that they looked at their osteotomy rates that were dropping precipitously, and they were already 3 times higher in Ontario. And so I took a look at this with one of our fellows. We looked at ABOS Part 2 data, looked at surgical treatment of primary OA in patients under 60. We looked at 17,000 surgeries and some of the common things that are done, totals, unis, osteotomy, or cartilage surgery. And the finding was that even in patients under the age of 40, total knees were outnumbering osteotomies. In patients in their 40s, they were 20 to 1, and in their 50s, over 240 to 1. And I think that we're failing our trainees because probably nobody here has seen an open Bankart that's a resident. Because if you stop doing them, you stop thinking about it. This was a study looking at the Shoulder and Elbow Society. And basically after 2001, if you hadn't seen it, you weren't ever thinking about it. So if you don't see it, you won't consider it. And then how do we do it well? Ultimately, out of a high volume center in Europe, they looked and they found that experienced surgeons did better. And we know from Mattson that the surgeon is the method. You'll never become a good surgeon if it has faded away over time. So if we look at our patient, opening wedge osteotomy with a modern implant, there are locking implants that are also much better than the staples that we used to use. And now here he is, doing his fitness training, and that he's standing on the leg that he had his surgery on, and his effusions went away. So currently, age less than 50, high demand patients, we know they're going to have lower satisfaction rates, higher conversion rates, better longevity in your conversion totals when they do come, because they're going to come. HTO is cost effective, and despite that, we seem to be walking away from it. Changing gears for a second, we'll talk about some patellofemoral stuff. This is the other thing that I get really excited about. Everybody loves anterior knee pain in their clinics, I'm sure. But here's a 15-year-old with low energy dislocations and funny looking x-rays and a high grade J sign. Here's a 16-year-old, similar story. And here's an 18-year-old that has bilateral recurrent instability. His parents are both therapists at our clinic, and they basically kept their kids away, or they kept their kids out of seeing doctors because they saw that patellofemoral surgery just didn't seem to be working out for them. And they rehabbed it forever. But for patellar instability, we have the MPFL, which according to this study from HSS, they looked regardless of patellar height or TTTG, everybody got an MPFL and 90% return to sport and only one redislocation. So, everything is awesome, works every time. They just recently published their 5-year follow-up. They thought this was a good result, and I think it's awful. They had only 50 patients out of their 138 that made 5 years in their cohort. Of those, 6 had recurrent instability at a mean time of 3 years, and they already got rid of anybody that had pain or what they called a jumping J. So this was their best case scenario. I personally don't think this is great. I think that the nuance that is presented in the title in some of these is totally lost. So I'm not sure that current approaches are good enough. This is a study out of the Banff group where they have done a lot of patellofemoral work. And even though in their cohort, only 3% of patients were redislocating, only half of patients said their knees were normal. And patients were always consistently grading their apprehension worse than what their surgeon was. So there's clearly more to life than just the MPFL. And I'm going to highlight axial malalignment. It's often listed in the algorithm, but rarely in the treatment plan. We all know what femoral anteversion is. We all see that on the skeletons. We know that we start with increased femoral anteversion at about 40 and it decreases over time. But when this patient walks into your clinic with the so-called squinting patella because their feet, when they're pointing forward, their patellas are severely angled in, they're struggling because they are losing the mechanical advantage of having their patella work as a pulley. And if you put their patellas forward, then you can see what the rotation of their limb is. There's a gold standard to quantify this. It cannot be quantified on isolated knee imaging. You need some sort of cross-sectional imaging of the hip, knee, and ankle. You can do that with an MRI, but it takes longer, and modern CT with limited cuts is far less radiation than it used to be. And we've known this for a while that some of these patients have miserable malalignment, some sort of weird torsional issues. These patients have pain and all sorts of compensatory problems, and it's hard to make these patients happy. And I was seeing so many awful patellofemoral patients that were so severely dysplastic and had increased femoral aneurysm that I was like, these have to be linked. So I looked at this with another fellow. We looked at a database of CT scans at an imaging center that I was using across my two practices. And we looked at femoral aneurysm, maybe there's some sort of Wolf's Law at play during development. When we looked at 177 limbs that had a normal distribution of aneurysm, overwhelmingly young patients, we were looking for correlations, and we found none. Basically, aneurysm was a completely independent risk factor to what we were looking at just dedicated knee imaging. So dysplasia does not run with malrotation, and you can't assume your knee imaging is going to clue you in. So for all of these patients, they'll get a hip exam. We'll just look at them when they walk in, scrutinize radiographs, think about abnormal stories, disproportionate pain, low energy dislocations. This might give us some degree of a hint. This has been described as the winking emoji sign. If you see this on your x-ray, think about it a little bit more. The overlap of the lateral femoral condyle and the lateral tibial spine is associated with through joint rotation, which does seem to run with femoral aneurysm, but not perfectly. So I know I probably still haven't made people care, and PT is still going to be the mainstay for a lot of anterior knee pain and recurrent patellar instability. But if you have excess femoral aneurysm, you are exaggerating the effective Q angle, and you're altering how your quads are firing. And it is hard to rehab these patients after isolated MPFL surgery if you haven't done anything about it. And I think these outcomes are inferior, and there's some data to show that. This is out of Brazil, where they looked at all their patients that had a TT-TG greater than 17, had MPFL and TTO. And turns out that their patient-reported outcomes for their excess femoral aneurysm did not improve as much. So the TTO did not make up for that excess version. Group out of Beijing also looked at this, and they had a higher cutoff TT-TG of 20, and patients that had a lot of these measures done in advance. And when they looked at those patients, they were normally distributed between normal version, high normal, and greater than 30. Everything else was the same. I probably should have just looked at this study because it said dysplasia was not associated with their version either. But when they looked at their patients, they found that those patients in that group of excess femoral aneurysm greater than 30 had worse outcomes, even with the MPFL TTO, and a much greater persistence of a J sign after surgery. So when I see this in clinic, and this is somebody's left leg and I'm standing at their foot, one option is to try to move their tubercle like up that way, or I can always just try to rotate the femur and start with a happier skeleton. So what happens when you do this? That group in Beijing changed their protocol a while ago, and then we're adding in these derotational osteotomies and now individualized for femoral aneurysm greater than 30. It turns out their outcomes started to improve again, and they had lower rates of residual J signs. And then when they looked specifically by J sign severity, the high-grade J signs were much better. They were now approaching normal version. So derotational osteotomy really shines in patients that have a high-grade J sign. There is still benefit, but less in the low-grade J sign. So what happens if you don't get it right the first time? I mean, this is big surgery. People don't love telling patients they need big surgery. Good luck convincing mom their kid needs big surgery. This is Schottle's PhD thesis, and he found that if you went big the first time, it was as good by your patient-reported outcomes as isolated MPFL surgery. But anytime you had to include a revision, or God forbid a revision plus combined surgery, those patients did not do as well. So plan it right the first time. If we look at our patients, this first one, 37 ephemeral aneurysm on the left, moderate dysplasia. So went ahead and did a derotational osteotomy. Sadly, I'm the only person in my institution that uses that device in the middle frame on the C-arm shot. But I still love it. I don't know if any of the residents know it here. Hopefully, fingers crossed. Oh, okay. A great way to get better compression than combi holes. And the reason why I use that is because I'll let people bear pretty much full weight immediately on these. If you compress the hell out of it, then they feel so much better. They recover precociously. So this patient walked in at 4 weeks, no crutches. I let them weight bear full immediately. Oftentimes they'll self-restrict for a while. But she said that she was pain-free by a week and rejoined all of her sports at 3 months. This was a little bit different. This one was actually a tibial torsional problem. And if you do your osteotomy above the tubercle, then the tubercle comes along for the ride. Little bit hairier, but these newer compression staples, again, compressing cancellous surfaces, I'm pretty liberal and I'll let people essentially weight bear as tolerated, lock straight, and then range unrestricted while they're seated. No further instability events, and her high-grade J sign is gone. This was our kid with bilateral. For him, his anteversion was worse on the left than the right. So on the right, he did have some alta, so I did a distalizing tubercle osteotomy. I always anteriorize just a little bit to avoid the reverse Mackay effect. And on the left, did a derotational. So he's another nice internal control. And I have a lot of people that talk to me and say like, but these are big surgeries, like, you know, this is a big deal for anybody to go through. But if you compress them with that articulated tensioning device, they will recover quickly. And he said that his derotational was so much easier than his tubercle osteotomy. And here he is at 3 months, and the pain that he had from surgery is completely gone. So in the same way that we would agree that this is an MPFL doomed to fail with that much dysplasia, that this MPFL is not going to be any better. And then changing gears one last time, we'll talk about sometimes we think we have the right solution to the problem and everything's going well until it's not. And now you got a tougher situation on your hands, and maybe you wish you would have gone bigger the first time to avoid that bad situation. So we'll talk about an ACL case. This is a 17-year-old, tore his ACL, antecedent knee pain. He's got some bad patellar tendinosis, so I'm not going to use his patellar tendon. And we know that graft selection plays a role in our re-injury rates. This study out of the Moon Group showed a 2.5 to 3-fold higher failure rate in allograft. And so serious ACL surgeons don't use allografts for their high-risk patients anymore. But how much slope is too much? We know, depending on the study, we're talking about risks that are even worse than allograft. There's no way that we'd accept grafts with 3 or 5 or 18 fold risks of failure. And nothing ruins good results like long-term outcome. And anytime you put the word catastrophic in your title, you're going to get my attention. This was out of Sydney, and they looked at 20-year follow-ups of their ACLs, and they found that adolescents with higher slopes were failing pretty dramatically and pretty quickly with an 80% failure rate by 20 years. And I don't want to do anything that has an 80% failure rate. Even the stability trial, which was supposed to be helpful and tell us that lateral extraarticular tenodesis was going to be the solution. They did a sub-analysis of their slope and age and still found that some of these patients were at 10 to 20% failure risk, especially with increased slope. Original description came out of Lyon, France for humans. They've tested it out and it worked out for their patient. And then there was a case report in the Journal of Knee Surgery out of the Mayo Clinic in 2015. But we are infinitely behind our veterinary colleagues because they've been doing this for decades. Your dog, when they tear their ACL, they do not get ACL surgery. They get plateau surgery. And the son of the orthopedic surgeon who described anterolateral rotatory insufficiency of the knee actually developed a jig and a plate in Eugene and published this over 30 years ago, hundreds of cases. And all of these really good boys and girls love their knee. So if we revisit our case, this is 15 degrees of slope, and he's going to get a soft tissue graft, and he's 17. So I'm going to go ahead and cut his tibia. and do his ACL. So you can see his quad harvest has been closed. We got some nice K-wires that are parallel around the tubercle. We've got a planned resection wedge. And this is my current construct, just a few compression staples with a graft down the middle. And yes, it's a bigger surgery, but if it's going to keep him out of my OR in the future, that's a win. That's how I sell it to mom, and that's how I sell it to patient. Compressing cancella surfaces loves to heal immediately. So where do I think the future is? I think that machine learning and AI is going to help us identify which patients are going to benefit from what operations. Unis are a great operation. I do more unis than like osteotomies. But I think that osteotomy is still underused. So I'm hopeful that this will start suggesting osteotomy more often again. Best practices for joint preservation. Dr. Bartoletta mentioned that valgus came from the femur. If applying some of Paley's principles, that's actually not totally true. It is more often, but more frequently people are doing double level osteotomies these days because it's easier to heal small corrections and you can maintain a better joint line. And that patient, when they eventually get their total knee, it's not as big a deal for the surgeon. There may be a role for fibular work only. If you don't have fancy implants in your country, you get creative. And it turns out that fibular osteotomy will also alter contact pressures without touching the tibia at all. There is still the perineal nerve in the way if you do it proximally. So that's a little pesky. But I think that there may be more to come on that. And then patellofemoral surgery in the future. This is in the yellow journal right now. What do you do with femoral anaversion? What's pathologic? And this is a systematic review of 325 knees for derotational osteotomy with one redislocation more than 2 years out. So if there's my encouragement for everybody is if you see the high-grade J sign or funny-looking X-rays, get the cross-sectional imaging. ACL surgery in the future. There's an exceedingly low re-injury rate in patients that have these deflection osteotomies. This was a recent systematic review. We are not talking about very many patients. That's 133 with only 22 primaries. But this is in JBJS last year. They're quoting posterior tibial slope greater than 9.5 as being the issue. So I do think this is going to be part of our algorithm for primary surgery. And even in soft tissue injuries, the skeleton still wins. So thank you to some of the people that got me interested in osteotomy. This was Chris Wall. He helped me identify that my favorite operation was an opening wedge HTO. To all the faculty at Harborview who made me comfortable with any sort of fracture or fixation work. To Dr. Amendola at Iowa, now at Duke, who really taught me how to approach the patient in front of me and that one size does not fit all. And then Dr. Taiji in Detroit, who changed my approach on rotational work. And if he hadn't shared patients with me and I hadn't seen some of these incredible outcomes, I'm not sure I would have taken these leaps in adult patients. So thank you.
Any questions? Favorite way to measure the tibial slope on an ACL patient?
Get as perfect lateral possible, at least 15 centimeters. The group out of NYU showed the more tibia you get, the more reliable it is. I'll do a perfect circle at 5 centimeters below the joint line, a perfect at 15, draw a line up there. The thing that I don't have the answer to is, is it best fit medial plus lateral? Lateral side is what pivots, but the medial side is what sees a lot of force. So I still kind of do some version of a best fit with 5 and 15 centimeters below the joint line.
I do a lot of osteotomy as well, and for patellar stability, I agree that the rotation is a huge component. One thing that I struggle with sometimes is the how to balance the tibial rotation versus the femoral rotation and sussing out which one clinically is more important. I know there's like a creative, people have give you markers of what is normal or abnormal. Like, how do you, in your practice, tease that out.
Yeah.
Dave, just for people in Zoom, you sound.
Sure. So the question from Dr. Hagan was, how do you suss out what's more important, tibia or femur? And that's a common question that I get. Realistically, I probably do 10 times more femoral work than tibial work. Part of that is the complication rate is higher on the tibia if you're going to go above the tubercle. And I think a lot of the deformity, like if you go above the tubercle, you get better results. So it also depends on the technique that you use to measure it. The Jarrett technique is what a lot of the radiologists use, which is best fit femoral neck and then posterior condyle of the femur. With patients that have like a valgus proximal femur, I don't think that's that great. So I use the wide look technique, which has a slightly higher normative value. For me, generally my cutoff is 30 of femoral anteversion. Average torsion is in the high 20s, so you pretty much have to be over 40 for me to do something. And I probably do 10 times as much femoral work as tibial work.
Yeah, this is a remote question from Alan Greenwald, and Dr. Greenwald says, I did many tubercle osteotomies for instability in the 90s and early 2000s using a proprietary system. Is that still being used? I'm not sure which system that is. I agree that there are good results if the tubercle is properly interiorized and medialized. How do you determine how much to move the tubercle, and what if there is medial wear?
Yeah, so that's something that I've gone further away from over time, actually. I've put less stock into the TTTG as, and I still do tubercle osteotomies for distalizing for Alta. I still use it to offload lateral and distal patellar lesions or patellofemoral lesions, but not as much in patellar instability as I used to. I did a bunch as a fellow, so I pretty much freehand everything with a one saw for one cortex, finish it off with an osteotome. And if I'm doing something, I'll usually move it about 8 to 10 millimeters, but I used to move it more. But I find that I'm doing less tubercle work than I used to and far more rotational work.
Well, that's a good question, Dave. So one of the things that used to bother me about the osteotomies back in the day when I would do some of them is that you're basically looking at a static shot of the leg, and you're correcting for that one position of, the knee we're talking about. But we know that there's translation, there's rotation when somebody moves their knee. Is anybody looking at what happens to contact forces, throughout the range of motion, whether there might be some subtleties as to how we can actually do these deformity corrections?
Yeah, so one of the things that's come out recently is as it relates to valgus correction, historically people had generally worked more on the femur, but some recent contact pressure studies actually out of Vail showed that if you work on the tibia, if you're lucky enough to have the valgus be split between the femur and the tibia, you'll actually get better benefit by working on the tibia, in the same way that if you're doing a total knee and you want to affect the whole range of motion, you don't work on the distal femur, you work on the tibia. So I think that there has been a little bit more of a bias towards working on the tibia and the valgus knee, and in the varus knee, you're right, it's a static picture, and there's a lot that goes into it, including ligament status, meniscal competence, that X-rays don't ever account for. I get single leg standing alignment views now when I'm planning because I want to see what the knee is like when we're simulating the single leg stance of gait. And that actually tends to exaggerate the deformity by an extra degree or so. Going back to my disclosure, that is self-serving because it means that I probably have more to do. But I think it's a better representation of how the knee is seeing force than a two-legged stance.
David, great talk. Thanks for coming to do grand rounds. I guess my question is off topic, but obviously we have a lot of residents here who are sitting in the same kind of place in the auditorium you were at one point. So kind of looking back now and having had such a good start to your career thus far, what would be some of your advice to our residents kind of for their time here and then obviously beyond? I mean, that's kind of a broad question, but maybe for when you were in their shoes looking back, what do you think was the most impactful things? What are the things that, you know, you wish maybe you had thought about differently, or some words of wisdom for our residents?
So from a practical standpoint during residency, and I stole this from Josh Lindsay, he said, ask as many questions as you can and don't be afraid to ask, seem stupid, and write them down, because you're going to leave here and thinking you know everything. And then you're like, oh crap, like how did that, like Dr. Tatesman made that look so easy, and I am not making it look easy. And if you write it down, I saved a lot of op reports. I saved a ton of x-rays. I have like multiple PowerPoints of like cases that I did from like PGY 4-year on. So from a practical standpoint, just start like recording things and put them, you know, in a HIPAA compliant way, wherever you can do it. But save that for later. And then later in your career, it's really easy to kind of go off and start a practice, and that's all really exciting. But what you learn here is just the beginning. Try to go to meetings that you wouldn't normally go to. And that can be everything, you know, everybody goes to the academy and your subspecialty society, but go to an international meeting. They are talking about these sorts of things way more frequently at international meetings. It'll open your eyes. Go to small meetings. Some of my favorite meetings have been, you know, Gilmer's Mammoth meetings, because you put like 8 of us in a room or 15 of us in a room, and we're like, hey, everybody says this, but like, I don't actually see that in my practice. Like, it's really helpful to have that sort of open discussion. So check out different meetings that you wouldn't normally go to, and try to never stop learning, because it's easy to fall into a rut and be like, cool, patellar instability, I got an MPFL for that. Primary OA in a 53-year-old, like, cool, I'm an arthroplasty surgeon, I got a uni for that. Get to know the people in your communities, because if somebody sends me an osteotomy to do, I'm going to try to send them cases back. So that way, you know, you're not burning bridges, but get to know the people in your community as well. And that's like, leads into the last thing. I'm heavily involved in the Michigan Orthopaedic Society. It's a great way to know your community, know your practice, and you'll find that you're not going to speak that badly about people once you've been like shared a beer with them at a meeting. And it's only going to help your practice as well.